Welcome to Insights to Hyperthyroidism, a comprehensive clinical, economic, and therapeutic overview of the overactive thyroid. The path to discovery began in 1786 with the first recorded report of hyperthyroidism. Key milestones include the linkage of palpitations to exophthalmos in 1802 and the detailed clinical descriptions by Graves and von Basedow. The modern era began in the 1940s with the introduction of radioactive iodine and antithyroid drugs. Hyperthyroidism stems from an overmetabolic state, which can be overt or subclinical. Graves' disease is an autoimmune condition where antibodies mimic TSH, chronically stimulating the thyroid. Toxic nodular disease involves autonomous nodules that overproduce hormones independent of the normal feedback loop. Hyperthyroidism affects about 1.2% of the U.S. population. In iodine-replete regions like the U.S., Graves' disease is the primary driver. Conversely, iodine-deficient regions see a surge in toxic nodular goiters, which are more common in older adults. There is a significant female predilection, with a 10-to-1 diagnostic skew. A woman's lifetime risk is 1 in 8 for experiencing a thyroid issue. Key risk windows include the postpartum period and perimenopause, as well as concurrent autoimmune conditions. Systemic manifestations are broad. Cardiovascular symptoms include tachycardia and atrial fibrillation. Neurological signs involve restlessness and tremors. Metabolic changes include goiter, weight loss, and heat intolerance. Gastrointestinal issues often present as frequent bowel movements and diarrhea. The classic presentation for those under 60 includes visible goiter, pronounced anxiety, and distinct tremors. For older adults, apathetic thyrotoxicosis often presents with severe weight loss and apathy, leading to misdiagnosis and dangerous cardiovascular issues like atrial fibrillation. Severe complications include thyroid eye disease and elevated risks during pregnancy. Treatments for hyperthyroidism carry a significant patient out-of-pocket burden. Surgical options can exceed $25,000, while radioactive iodine is around $4,000 plus fees. Lifelong maintenance following ablation adds ongoing monthly costs for levothyroxine. The 10-year healthcare trajectory reveals a cumulative financial burden of $20,000 to $24,000 plus per patient. Costs are driven by frequent lab monitoring, specialist consultations, and complication management, such as for hepatotoxicity or vocal cord palsy. The hidden systemic burden extends to public and employer costs. Autoimmune conditions for every 1,000 employees generate over $500,000 in excess costs driven by absenteeism and presenteeism. Thyroid eye disease alone is projected to cost $26 million to $35 million over 5 years due to disability and specialized care. The primary therapeutic triad includes antithyroid drugs like methimazole, which halt hormone synthesis, radioactive iodine, RAI, which destroys hyperactive cells over months, and surgical thyroidectomy, offering immediate resolution. Beta blockers are used as adjunct therapy for rapid symptom control. Comparing treatments, ATDs take 12 to 18 months for effect and have a high relapse risk. RAI is faster, but carries a high risk of hypothyroidism and can worsen thyroid eye disease. Surgery offers an immediate, guaranteed resolution, but carries risks like vocal cord paralysis and hypoparathyroidism. Historically, destructive ablation like surgery or RAI was the default, resulting in lifelong hormone dependence. The modern preference shifts toward prolonged ATD therapy to maintain a functional gland. The biological future is moving toward targeted cellular therapies, such as tecloprotumab, to treat conditions like TED without organ destruction. This video's content is supported by citations and clinical references spanning history, pathology, economics, epidemiology, and clinical guidelines.